Very good afternoon. Thank you, Dr. Dipankar, for having me in your instruction course. So my topic is clinical pathology of viral retinitis. It sounds very simple, and I'm sure going to show you simple cases. So this is the first case of a 34-year-old male. I'm not going into literature because I was strictly told it has to be case-based. A 34-year-old male presented in January last year. He was a known HIV positive. He had completed art therapy, and he had both eyes decreased vision, light perception in both the eyes. He was treated elsewhere 1 month ago, and this was the fundus picture, both the eyes. It's very obvious the diagnosis is a known HIV. So we're obviously dealing with bilateral CMV retinitis. The anterior segment photographs a bit of endothelial dusting. We really don't see much of reaction in these eyes, but what was surprising was bilateral posterior subtenon deposits. He was treated elsewhere. So he was treated as probably a non-infectious uveitis or a retinitis, I don't know. So this is what exaggerated the disease in his both the eyes, because he had not completed his ART. So we treated him with bilateral intravitreal ganciclovir, though under guarded prognosis because we were not very hopeful of the visual recovery. And we did take an AC tap for CMV virus, and it turned out to be positive. So you can see the amplification curve, very much similar to the positive control. And this is the melting curve, again coinciding with the positive control. So he went on to receive multiple intravitreal ganciclovir injections and also received oral valganciclovir. And this was the baseline presentation and at least anatomical outcome we could achieve to some extent. And the lesions resolved very fast. So this, we demonstrated the presence of CMV virus in the anterior chamber, but if it had been done timely, the prognosis would have been much better. So this was a case of CMV viral retinitis. Second case was a 69-year-old male. Just look at the age. So this is not the very typical age of presentation of viral retinitis. He presented in March this year, decreased vision in the right eye with pain and redness since 15 days. He gave history of hernia and prostate surgery. He was hypertensive, no other systemic complaints. His HIV TPHA was negative. So this was the clinical picture. His vision was 624 despite so much of vitritis, and you can see multiple tiny discrete retinitis lesions all over in the periphery, along with tongue-shaped lesions of retinitis. So we had both. His IOP was fine. He had KPs, 2+ cells, posterior synecdoche. Corneal sensations were normal. So this was the left eye. It was normal, no complaints, 6/6 vision, but we saw some of these spots in nasal periphery. So they looked inactive. However, we did the OCT through these lesions, and it was just some pigmentation and scars. So the fluorescein revealed vascular leak along with the hypofluorescence along the lesions, and the left eye did not show us anything. So we were sure we are dealing with a clinical diagnosis of acute retinal necrosis in the right eye. Because the age was 69, so we had to think of possible other causes. We did an aqueous tap from the right eye for PCR viral and IL-10, IL-6. VZV was positive, so with the baseline RFT, we started him on IV acyclovir, plenty of fluids and oral prednisolone. And again, you can see this was the PCR curves of the test sample. And this was at 5 days, and this is at 1 month. So he's on follow-up now, shifted to oral acyclovir along with steroids. So this was a case of VZV viral retinitis. So we had this is the third case and my last case, a 47-year-old male, but this is a long case. So 47-year-old male, he had right eye acute retinal necrosis, presented in September 2015, almost 10 years ago. He was HSV positive from the aqueous tap. We treated him with IV acyclovir, oral steroids, and he did fine from September 15 to February 2016, almost 6 months. And in February 16, he came back with the recurrence of vitritis and the tongue-shaped lesion, the previous reactivated lesion. Again, he was in maintenance dose of Valsivir. It was high to 1 gram TID. Oral steroids were restarted, and he kind of did all right till May 2016. He was lost to follow-up in 2017, and he came back in March 2022. So there was loss of follow-up because of the COVID, and we don't know whether COVID had a role because he had already developed a recurrence before COVID. So he comes back in March 2022. His anterior segment picture was almost the same as what we saw at initial visit: corneal opacity, iris atrophy, and this was the vitritis in the same eye, active retinitis lesion. We started him again on IV acyclovir, gave it for 2 weeks with oral steroids. He did fine till September 23, and which again he was put on maintenance dose. And so this was basically the flow: September 2015, 2016, then recurrence in March 2022, and 2023 he was fine on maintenance dose. So this year again we saw him in January. He's a very well educated gentleman from a very good family. He's very much aware of his symptoms, of his treatment, very compliant regarding his treatment. So January this year he came back with the same eye involvement, decreased vision since 2 weeks. Now you can see he had recovered a vision of 6/6 in the left eye. He goes down to counting fingers close to face. You can see severe vitritis, and the same infranasal retinitis lesion had shown reactivation. So this was, we made a diagnosis of recurrence of AN, admitted him, IV acyclovir with the baseline RFT. So the expected protocol was the same, but to our surprise, his it's a long thing, but I'll tell you, after 4 doses of, maybe 3 doses of acyclovir, he complained of decreased urine output. He was admitted with us, so everything was easy to manage. His creatinine was high, urea was 80, creatinine 2.5. We stopped IV acyclovir, we started IV fluids, got a nephrology consultation, and this was after 5 doses of IV acyclovir. Now what do? You stop IV acyclovir. So his investigations showed that his creatinine kept on rising despite stopping acyclovir. Urea kept on rising. So this was the sequence: 11 Jan, 12 Jan, 13 Jan, 14 Jan. His creatinine had shot up to 10. Now he was shifted to nephrology ward. It was scary. They diagnosed him probably as acyclovir-induced toxicity leading to rapidly progressive renal failure, or complementary and alternative medications, because he did give history of using some Ayurvedic medications. He was started on hemodialysis, planned for a renal biopsy, which confirmed acyclovir-induced crystalline nephropathy. So because we could not give him acyclovir, the nephrologists tell us that we have to give dose-adjusted antivirals in these patients, and these are the various formulas we resort to based on his creatinine clearance, which was 10 milliliters per minute. So oral steroids were started, and we gave him oral Valgan along with intravitreal ganciclovir because we were desperate to give him antiviral cover. So this was his progress from counting fingers. He improved to counting finger half meter within 4 days after oral and intravitreal Valgan. After first injection, second injection, and 9 days of oral Valgan, his vision improved to counting fingers 5 meter. And this was his latest follow-up. 3 months, at 3 months, his vision is now 6/9. He's on maintenance dose of Valgan. So the challenge is there are cases of recurrent acute retinal necrosis which have been reported, and there is no evidence of delayed recurrence of AN, and what is said is that herpes AN is more likely to recur as compared to VZV AN, though recurrence is extremely rare. So we need to keep that in mind, and that is where the importance of CPC comes. I'm not saying HSV AN should recur, but if it recurs, you are warned as an ophthalmologist. So this was a case of HSV recurrent viral retinitis with acyclovir-induced nephrotoxicity. But since we knew it is an HSV viral retinitis, we could manage with alternative regime. Thank you very much.
Thank you, Dr. Reema. It's a wonderful clinical presentation mostly. But I want to ask JB sir, so his experience on the enucleated eyeball of a viral retinitis, what are the inference for those?
We have 2 eyes of acute retinal necrosis, and what we could see that there is a full thickness retinal necrosis occurs over there, and what happens is that there is a vasculitis involved. The vessels are inflamed. Surrounding there is acute inflammation was seen, or also I could see the endothelial cell proliferation, and within there is a herpes virus that was due to herpes virus. We could find the inclusion bodies also in the herpes virus. So we couldn't do the electron microscopy. The electron microscopy was not working. Transmission electron microscopy we wanted to do. We couldn't do that one, but we could get that inclusion body.
Thank you, sir. Reema, do you see again a mixed infection, CMV versus HSV versus BJB when if you do primer for all run primer for all the 3 PCR, sometimes they are all 3 are positive?
Yeah, we always run all the primers for all the viruses together, but I haven't found any coexistence as such.
Okay.
Thank you, Dr.